What if you're sick and you can't pay for health care? What if your child needs medication you can't afford? The poorest South Carolinians have access to medical care if they can find a provider who takes Medicaid and if they have transportation. But 1 in 5 South Carolinians has neither government-paid health care nor access to private health insurance. These people often don't seek medical care except for the worst emergencies because they can't afford it. On this show, we'll meet South Carolinians who are providing care to the uninsured and others who are asking why any South Carolinian should have to go without medical care. Maybe you think this show has nothing to do with you, but it might. What if you were sick and you couldn't pay your medical bills? I'm Pat Jobe. Thank you for making the connection. Jeff Youngman is the clinical director for the free medical clinic here at Crisis Ministries in downtown Charleston. They provide medical care for homeless folks. And Jeff, I kind of put you on the spot earlier and asked you if you got a good story about somebody who's been homeless who you guys have been able to help with this medical care. Can you tell us maybe a story of somebody?
I can tell you some stories. I can tell you a lot of stories.
Good, we like stories. That's what it's all about.
The person I was thinking of was a woman who stayed here at the shelter and came to us because she hurt her hip and was unable to work. And over the course of time, the medical clinic worked with her and was able to get her referrals to places that could help her somewhat, but couldn't help her enough because, of course, she couldn't afford the help and she needed a surgery to get her hip replaced. So the medical clinic provided enough care to keep her going and enough referrals to get her to the places she needed to be at. In the meantime, we were able to work with her. The social work staff was able to work with her to get her on disability. And once she got on disability, she had everything in place then to be able to get the surgery she needed once she had the Medicaid coverage so that she could get the surgery.
She was living in the shelter and working?
No, she was working prior to coming to shelter, injured her hip and can no longer work. And
so that's what made her become homeless?
Lack of medical care combined with a lack of affordable housing are the two major causes of homelessness in the country. So once she was working a job where she wasn't insured or didn't have the benefits and was unable to work because of her hip injury, she lost her apartment because she couldn't afford no income, no apartment. So she had to come to the shelter.
You think decent health care is a basic human right?
I think universal health care is a basic human right. I think everybody should be afforded health care in this community. If we had health care for everybody, the number of homeless people would be cut dramatically. If we had affordable housing, if we had a living wage, those three things alone would solve a lot of the homeless problems that people want to solve the homeless issue, but they don't want to put it in the areas that they need to get these problems solved.
Well, I had it diagnosed about 2 years ago, and I've been struggling ever since. I can't get any type of Medicaid or any type of assistance to even help me get the surgery. And I know I have to have it, but I can't afford it. I went for Medicaid maybe 20 times. They turned me down every time.
That's because of too much income?
Exactly. And like I said, it's so hard for me. I've been trying for years to get this surgery done, but it's impossible with no insurance. They're asking me to make payments, and I'm barely making ends meet for me and my 2 children. It makes me feel bad. Look at my children are my pride and joy. I love them very much, and I explain to them all the time. Mama doesn't have it. She has. I try my best to get it for them, but with the cancer, they know Mommy's not gonna be able to walk. You know, if I had the surgery, whenever I can't afford or Lord provides me, I get it. I will not walk for 6 months to a year. So my kids are still gonna be without.
Anil Perot is director of the MUSC Cares Clinic in Mount Pleasant. It is a clinic run entirely by medical students and volunteer physicians. It's a free medical clinic. Anil, tell us what goes on here.
Well, basically, CARES stands for Community Aid, Relief, Education, and Support. And it's a free clinic that was started by a couple of medical students 2 years ago. All of our patients are actually uninsured patients who have very poor access to health care. So twice a week between the hours 6:30 to 9 on Tuesday and Thursdays up in Mount Pleasant, we do see these patients who otherwise would not have any access to health care.
Can you think of a particular patient that you've worked with or a story you've heard from some of your colleagues about the work of this clinic?
We have this one patient. He's an Hispanic individual, basically suffered an accident a couple months ago, suffered a brain injury, and that's kind of left him paralyzed, arm and leg, and he was unable to walk. And just based on our collaborative effort, it's gotten to the point where he can now walk, he can now walk compared to, a couple months ago where he was just basically wheelchair bound.
What does it feel like? How does it touch your heart to have been that injured and now be able to walk again, be able to use your arm again, and to look forward to the day you're going to be able to go back to work?
¿Qué sientes en tu corazón de estar otra vez recuperándote y estar mejor y tener la esperanza de trabajar?
Wow, pues muy bonito.
Very pretty.
Como si volviera a nacer, tal vez.
like he is born again.
Born again.
Born again, yes.
Born again. Very, very powerful. Very powerful. Okay, Catherine, you're somebody who has come up against a situation of being sick and not having health insurance. And you've come to the CARES Clinic, which is operated by MUSC students. And how has that made you feel? What's that experience been like for you?
It was really relieving to know that there was actually a place. I went to another place that accepted people who didn't have health insurance, and I ended up spending $150 on that visit. So it was nice because I can't really afford that.
Anil, is this typical of the kind of patients that you all deal with?
This is really typical of the patients we kind of see at this clinic. Some of the clinics do, accept patients that don't have health insurance, but when they get their bill, they realize it's in the hundreds or even thousands of dollars, and they can't afford to pay that bill. And for them, for a lot of them, that means either not paying the bill and not seeing a doctor again in the future, or not even worrying about their health problems and just kind of living with it. So this is very, very, very typical of the patients that we do see at this clinic.
When we started practice, we didn't have insurance.
And when was that?
And that was in 1961. And it was just a wonderful period of time where we could take care of the patient, and we didn't have to worry about who was going to pay the bill, because the patient paid the bill, or they didn't pay the bill. That was okay too. We could take allowances. We had so many opportunities to service our patient in unusual ways. I think the most unusual one that I can recall was a little Fanning boy, and he lived down close to the Ashley River, and he loved to go down on the river, and his mother had told him not to go to the river that day. Well, he fell, and he got a laceration on his leg, and of course it tore his little pants, and he came up to the office on his bicycle, and he said, "Dr. Margie, I've got to get all fixed up." So I stitched up his laceration, and then he turned around and he said, "Dr. Margie, can you sew up my pants too?" So I did, and I guess that's what we call total care.
Dr. Peter Kafoury is a chiropractic internist whose practice is here in Charleston and who has lots of interesting opinions about access to health care. Peter, thanks so much for being on the show. We're delighted to have you. You and I were talking the other day about the problems that are in our health care system. Why don't you tell us how you see all that?
There's a lot of problems, and if the topic is mostly access to health care, I think it involves a lot of things, but it always boils down to money, it seems, and the haves get what they want and the have-nots don't somehow. From my particular point of view, I'm concerned about people having access to alternative health care in a fair and equitable way with conventional medicine as well. In my field, we are covered, quote, end quote, by Medicare. But let's use that as an example, because Medicare covers chiropractic, but to such a limited extent that it makes it extremely difficult for people to get what they need. So if the average cost of an office call, for example, is $50, Medicare is likely to pay maybe $26, $28 of that. and they'll put very rigid restrictions on how many visits a person can make, how long it takes them to pay, and so forth. I often tell people that if Medicare was a product sold on the open market and not something that they were forced to take when they were 65, no one would buy it, because it's really not a very good product.
Dr. David Albenberg is one of the physicians here at Access Healthcare, and it's a radical approach to dealing with providing medical care here in the Charleston community. David, tell us how you get into this, what you're trying to accomplish. Tell us your story.
Right, well, it definitely is radical, but we prefer to think of it as more innovative. It's sort of a free market approach towards healthcare, getting away from the sort of third-party payers that have complicated relationships between doctors and patients. This is different than the third-party payer system, the insurance model, where you pay $10, wait an hour, and then see your doctor for 10 minutes, and you tolerate that because you're not really paying for your insurance. Your employer is, and that's sort of where this all kind of went awry. This is very different. We say, you know, you're going to pay 100% for this product, and if you see value, we hope that you'll stick with us. If you don't, you probably won't.
Do you think the whole system can be consumer-driven?
No, I really think that this is a niche market. Ideally, what would I like to see, because you're asking, I would like to see more practices try to find innovative ways to answer the questions, what is it that patients want, and come out there trying to provide that for patients. I'd like to see a stronger safety network in the way of the Medicaid system and our pooling our tax money towards that safety network, where that everybody has a sort of minimum standard, minimum bar of health care that they were able to get. And I'd love to see more and more incentives to take the third-party payers out of this, the employers who are now providing the majority of the health care and have very little, if any, interest in the actual health of their employees. So it's actually possible to provide medical services in this environment and still feel very strongly about things like Medicaid, underprivileged care, universal health care. So it is not, they are not separate thoughts, and they're not mutually exclusive.
When the patient has to pay for what he acquires, he's a little bit more selective in what he's willing to pay for. When the insurance came, the insurance paid for everything, then there was no limit to it. And this didn't work very well for the insurance company, so they began to be rather stringent about what they would allow. And this is where all the rules and regulations came in, dictating not only what you could charge, but how long you had to stay with the patient and how many patients you had to see per hour. And one of the most prominent reasons why I elected to retire, I got a letter from one of the insurance companies telling me that I had prescribed a certain drug, I think 17 times in the last 30 days, and that was not the preferred drug. Preferred meaning the cheapest thing that you could acquire. But I was describing the generic, a brand name rather than a generic. And if I didn't change my ways, they would have to make some adjustments on my reimbursement.
Mount Holly is a self-insured company, which means we insure ourselves. Last year, our cost per employee was $14,500 for health care, which did not include the employee's contribution. So that's a little over $9 million that we spent on health care last year alone.
Has the cost of providing that kind of coverage, has that gone up in recent years?
Absolutely. In 1996, that same, if you look at apples to apples, that cost was $4,800 per person. So in that period of time, a little over 10 years, it's gone up almost $10,000 per person per year.
What about small employers? What are they able to do for their employees in terms of health coverage?
Well, obviously, if you're looking at double-digit increases almost every year, it comes to the point of no return. All employers want to make sure that they provide their employees with the best benefits that they could possibly get. But over a period of time, as that cost continues to escalate, one of a couple things are going to happen. Either the company is going to finally say, we can't afford that benefit anymore, or they're going to say, we're going to have to reduce the level of that benefit. Or the third thing is what you're seeing now, the cost will have to be shifted to the employees.
If there was no such thing as health insurance, we would revert back to a free market economy. Doctors would charge what people could afford to pay, and prices would come down to a realistic level. Now, on the other end of the spectrum, okay, I do favor universal health care. And in a universal single-payer system, My concept would be that every citizen would be covered equally, and every healthcare profession that's licensed would be covered equally.
Murray Neal is Executive Director of Charleston Area Therapeutic Riding. Murray, give us the thumbnail of the program.
Well, Charleston Area Therapeutic Riding works with children and adults with disabilities doing therapy using the horse as a therapy tool. And the biggest bonus to using a horse is not only being out here in the open and the horses, the relationship the students have with the horses, but the horse has a movement that is very similar to the way your pelvis moves when you walk, and so we can strengthen students' physical abilities.
So Kissy, tell us about Callie's diagnosis and about your journey through this whole process.
Callie's diagnosed with mitochondrial myopathy. It's a muscle disorder, and she has low muscle tone. And when she was, I guess she was 3 when she was old enough to start with the program, and she's 9 now, so she's been riding for about 5 years. Physically, she can tell the advantages of the hippotherapy and the strength that she has at home. She's doing some walking on parallel bars with minimal assistance, standing with minimal assistance, and walking with assistance. She's at a state where she's progressed slowly at her own pace, but she's continued to progress, which is a tremendous leap for Callie.
How do you feel about the level of assistance that you've gotten?
By the time Callie files for physical therapy, occupational therapy, speech therapy, they're not going to recognize hippotherapy. It's all exhausted by the time hippotherapy knocks on the door.
Murray, tell us about the foundations and the individuals who support your work and how you feel about those folks.
Oh, well, that's easy to talk about them. We have been blessed with enormous community support. We get a great deal of support from local foundations, a lot of individuals who are just interested in education. Children with disabilities are interested in horses, give us a lot of individual donations, and then we also write a fair amount of grants locally and nationally to receive support. So all those people enable us to do what we do, and we do have a fee for services, but we also have a policy that we never turn anyone away because of inability to pay. So everyone who qualifies medically and otherwise to participate can participate.
Joe Gillum, you're Callie's dad, and you've been involved in this journey. What has it been like for you?
It's been fulfilling to see her mature physically. When she first started riding, she could barely hold herself up straight, and now she's standing up straight. She can gallop, she can walk around. It's just amazing that the program and all the volunteers and all that they do out here. I don't know what we do without the network. Through all the therapy and the programs that they have, there's just so many people that give so that Callie and others like her can thrive.
Dr. Carolyn Thiedke is a member of the faculty at MUSC, and she is also a member of Physicians for a National Health Program, which is a group of doctors advocating universal health care. Dr. Thiedke, thank you for being with us today.
It's my pleasure.
Tell us about treating uninsured patients.
There was a stigma to those patients. It's as if we were blaming them for the failings of our healthcare system.
I went to DSS to try to get help when I got laid off, and I was told I'm not eligible. You're not 65, you're not totally blind, you're not eligible. We can't help you. All I want to do is get healthy enough to continue working. And I was told, well, sorry, can't help. Things got so desperate for me that I actually considered committing a crime against a federally insured institution just to get the help that I needed. They'd have to keep me alive to prosecute me.
One day I was flying to a meeting, and I had checked a book out of the library that I read a review of in Time magazine, and it was a book called Critical Condition. And it literally was an eye-opening experience for me. They were saying things that I guess on some level I knew but had not really personalize them. You know, just talking about how broken our healthcare system is, that there are millions and millions of people in the most prosperous country in the world who don't have access to healthcare. And the ramifications for those people and for our society as at large. It was like waking up from a deep sleep. It was the first time it occurred to me that this was an issue that needed my attention and the attention of others in the community.
So you came to the conclusion after reading the book that the system is broken. What's the fix?
Well, the only way to provide universal health care so that every man, woman, and child in the United States is covered is to go to a single-payer health care system, which is similar, it wouldn't have to be identical, but similar to what they have in Canada. But I'm quick to say it's not socialized medicine. That's something people often say, oh, well, you're talking about socialized medicine, but we're not. The physicians would not be salaried by the government. The hospitals would not be owned by the government.
Having practiced medicine, having dealt with patients, having been on a one-on-one relationship with people who are sick and you're trying to get them well, what's going to be the difference?
The American doctors are the most paperworked, hassled doctors in the world. I mean, as it is now, physicians deal with so many different health plans, and they all have their own rules and regulations, they all have their own drug formularies, and so doctors' staffs have had to increase to reflect that. To me, this is one of the most amazing graphs, and it shows the growth since 1970 in two sectors of the healthcare business. This thin bottom line is the growth of physicians. So since 1970, you can see there's been some modest growth, as you would expect. As the population gets bigger, we need more physicians. This line here that looks like a mountain is the growth of the number of administrators. A lot of this is what is responsible for the spiraling healthcare costs that we as a country cannot sustain.
I started getting some phone calls about my bill, a bill in particular, and I was trying to make a payment on the bill because I planned on making a substantial payment on my bills, and they were not accepting what I was willing to give them. And it was almost, instead of feeling like customer service and someone trying to help you pay your bill and help work with you with your bill, it felt more like collections. When I opened up the bills, I was real stressed out, and I felt like I had a lot of weight on me, and I cried. I didn't know really who to turn to, and just saw this large number sitting in front of me, and I'd never had debt in my life. It was confusing because I had so many different bills, and they were coming from different places, and some that I knew I was being billed, but I didn't remember seeing or going somewhere. You know, different hospital names were on some of them.
If you had grocery insurance, a loaf of bread would cost you $30. Mm-hmm. Because the very concept of insurance drives up the cost of the product to unreasonable levels.
You know, physicians care deeply about their patients, and it's really hard for us to try to figure out how to get the medication for a patient who doesn't have insurance, or how to get that patient back for their follow-up and appointment. And I mean, it would be a wonderful experience to know that that's no longer an issue, that if you want that patient to have surgery or a procedure or to see you, that's not an issue anymore because they have health insurance.
When people don't have what they need, whether it's food, clean water, services, I think they get more angry. You know, as Bob Marley said, a hungry man is an angry man. Okay, and I think that it sets up an inequity in society that leads to more violence, more conflict, and ultimately, I think it's a formula for society's downfall.
Because of the introduction of insurance into the world of medicine, we had a lot of dictation not only what the patient could choose, but also what we could choose. And it all boils down to the mighty dollar. And it's scary to know that a patient will be denied certain type of medical care because their insurance refuses to cover it.
We've all seen the jars at the checkout, you know, asking us to give us our nickel and dime so that somebody can get their transplant or their chemotherapy. You know, again, I think it's a huge injustice that in the richest country in the world, people have to have bake sales and jars at the grocery counters to get the health care that they need.
We do a thing at the end of our interviews where we evoke the old Michelangelo painting where God is bringing Adam to life. Thank you for making the connection.
Thank you for allowing me this opportunity to speak about something I feel very passionate about.
Well, that's obvious.
What do we do now? Do we create a single-payer system and therefore turn control of medical care in America over to the government? Do we do a better job of telling people about free medical clinics? Do we create a more effective public transportation system? Or is this something you don't want to think about? Do we create a rising tide that floats all boats, or do you want to just paddle your own little canoe? These are questions that have dogged the steps of humanity from day one. Is medical care for all a challenge for all, or is it a dog-eat-dog world where the best thing you can do is figure out how to keep from getting eaten? Go to our website, theconnectionshow.org, and learn more about healthcare in South Carolina. Let us know what you think, support us financially, get involved so that more South Carolinians can make the connection. I'm Pat Joe. Thank you for making the connection.
Thank you very much. Yeah, it was wonderful. You guys come on and help me.
Well, good.
Thank you so much.
When we listen to the story and we see the world through someone else's eyes.
Thank you so much.
You didn't.
It can help
Thank you
us
for making it. Okay. Thank you. Yeah,
as
you're
they
a great guy.
talk of
Appreciate it.
what's important in their lives.
Very good. Very good. Go high. Go high. Very good. Very good.
We start breaking down those walls.
He's good at the high fives.
We're not so different after all.
Yeah,
We're making the connection. Making the connection. Making the connection.